All right, let's get started. First, I'd like to welcome, this is our first round of recruiting folks, and so we've got a lot of people from all over the country here to hopefully learn a lot about our department. So let us welcome them. I hope you learn a lot about us while you're here. And giving our grand rounds today is Dr. Wundes. Did I say that right? Yes. All right. So Annette is our MS guru, and I don't have anything more formal on her, sorry, but she's the person, the go-to person with all questions MS. And you are talking to us today about, it sounds like some research that you've been doing. Do I have that right? Partly. Okay. All right.
Okay, so okay, guys, I also want to give a warm welcome to all our, the applicants and the persons are visiting for us, but obviously all the other ones as well. Let me get this straight. Sorry, guys. Okay, so yeah, today's grand round is on autologous stem cell transplantation in MS and some other autoimmune neurological diseases. My disclosures are here, nothing pertaining to this presentation. And I would actually like to start with a patient story. I would like to introduce you to the first patient I ever met who then went on and got stem cell transplantation for MS. And this is actually a real picture of her. I think it's really HIPAA compliant because none of you will recognize her, but you may recognize a little bit of her zest in life. I'm not sure if this comes out very much, but this is one of these flying things where the air pushes you up. When I met her back in 2006, she was sent to us for not controlled MS or uncontrollable MS with the agents we had available at that time. So she had been on multiple agents, Avanex, as one of the interferons, the other interferons, Copaxone. She was on chemotherapy as well. So she got Noventron infusions, and then chemotherapy was also added to her standard DMT treatments. And my job at that time was, when we had this consultation about what other treatment options would be available for her, there was that we had opened just an investigational trial on stem cell transplantation and multiple sclerosis. So my job at that time was to dig really deep in her clinical course in the last few years, whether this is something we could consider for her. So I have very detailed information on her for the 2 years prior to the stem cell transplantation. She actually did receive stem cell transplantation then in early 2007. And we have followed her now for 8.5 years thereafter, 5 years of which were the formal clinical trial. And I can give you a little bit the before-after scenario. And I'd like to have you realize that this big arrow would be the time of the stem cell transplantation, and then the time thereafter she has been not on any disease-modifying therapies. So the first piece of information I had to collect on her was the number of relapses. She actually had a total of 8 relapses in the 2 years preceding the stem cell transplantation. She hasn't had a single one thereafter. She had a number of MRIs trying to control her disease. So every of these bars means that she had an MRI. If it's red, means she had enhancing lesion. If it's green, it means it's stable. She had a minimum of 3 enhancing lesions, often more than even 10 enhancing lesions on any of these scans. She had a number of MRIs, as you may envision, as part of this investigational study. The vast majority of them were clean. 3.5 years after the stem cell transplantation, however, she had then one MRI which showed one small contrast-enhancing lesion, and roughly a year later there was another MRI which demonstrated one punctate-enhancing lesion. You may wonder what are the holes in the schedule of the MRI. Was this so irregular? She actually had a baby because she was clinically so sterilized that she felt for the first time in her life that she felt like, oh, maybe that is an option for me. And she had a healthy boy, followed by a second healthy boy. In terms of her clinical progression, part of the eligibility criteria was that there was sustained neurological decline while being on standard treatments, and she had an EDSS decline of 1.5. For those in the audience who don't know what an EDSS of 4 means, that means that there's gait impairment, but she was actually still pretty functional in her walking nevertheless. An EDSS of 5 means she cannot walk more than 200 feet in one go. She did have functional improvement thereafter and has consistently an EDSS of 4.5 at this point in the 8.5 years after stem cell transplantation. So what I would like to accomplish today is talking more about the procedure she received, and I've divided this presentation today in 3 parts. The first one is almost like a didactic. What does it mean if somebody undergoes a stem cell transplantation? Then I want to go a little bit what's the current status of autologous stem cell transplantation in MS, and I will give you in the third part a little bit an idea what our group is working on, other than the current trial, which I will include as well. So let's start with the background and the rationale. Why do we even talk about autologous stem cell transplantation in MS? What's the hypothesis or rationale behind it? So we all know with the autoimmune disease that we think about it as a self-reactive autoimmune system. And our goal or rationale would be to get hopefully rid of that one and to reestablish a new self-tolerant immune system. If MS would be entirely driven by genetic factors, an autologous stem cell transplantation obviously would not make sense at all because you give the person their own stem cells back. However, we know that many of the autoimmune diseases, including MS, have a large contribution from environmental and regulatory factors, which then, on the background of some genetic predisposition, decide whether or not MS actually established. Also, if we had an easy way of treat and control MS in all patients, we wouldn't talk about autologous stem cell transplantation either, but we need to realize that there's a subset of patients with rather aggressive disease which are refractory to our treatment options. And to bring this up quite openly, maybe initially when that was started in the early 90s, people had the hope, maybe a little bit naive from nowadays point of view, that this may be a cure for MS. It's clearly not a cure for MS, but we're thinking about the goal of a long-term disease modulation. So before somebody goes on towards stem cell transplantation, there's a pretty hefty schedule of what needs to be done before. It starts with intense consultations on the risk-benefit ratio. In our case, there are often several consultations with a neurologist who is involved in stem cell transplantation, and then with a transplantation specialist to go into greater detail on the procedure itself. And in the United States, at least, basically that happens with insurance approval. So you may imagine when you're kind of fighting about simple things in daily life with your insurance, you will be fighting about this one as well. And so that is a lengthy process where Bernie sitting here and Dr. George Georges from the Fred Hutch are deeply involved on writing appeal letters to justify why stem cell transplantation in a particular person may be warranted. Once we have green light on both of these ends, then a pretty hefty schedule for the person starts with a comprehensive assessment of their overall health. Basically, you want to make sure that there are no unknown risks for them to undergo stem cell transplantation, or they go a number of procedures here. Primarily, you also want to eradicate all possible infectious foci, so that means dental exam, root canal, pulling of teeth, whatever is needed to come to that state. They need an IV line, and you have at least discussion regarding cryopreservation of sperms or eggs. But as my case illustrated you, it does not mean if somebody is undergoing autologous stem cell transplantation that obligately they are infertile. Then the stem cell transplantation itself we can think of as a 3-step process. The first step is, the technical term is mobilization, which is followed by apheresis. So we all know that the stem cells are living in the bone marrow, so you have to do something to get them out of the bone marrow into the bloodstream, where you then can wash them out of the bloodstream with a procedure called apheresis, that you get your holy graft there. In terms of the stem cell transplantation, to get the stem cells moved from the bone marrow into the bloodstream, you give GCSF. And to this general procedure, there are a few maybe little caveats to mention. In the stem cell trials, and most of the stem cell trials, you actually also give Cytoxan, and I came across it the first time. I was a little bit confused because my understanding was like, that's a chemotherapy, immunosuppression, but it's actually a stimulant for endogenous GCSF as well. So if you combine GCSF and Cytoxan, you have a much stronger response of the stem cells. You get a much better harvest, if you want to put it this way. Over the years, we, however, learned that giving GCSF is associated with a risk of an MS relapse. So what we do, and which is actually very effective, is we give prednisone coverage through this time frame. Then on the other side of the graph, there are also a few features to say. So you know that with the apheresis, you have all these cell bodies, all the cellular components of the blood, red blood cells, white blood cells, and only a small portion of that after the stimulation will be the stem cells. I don't go into much detail to what transfusion medicine has given us as nice tools to give the concentration on the stem cell higher. But then there's additional procedure which can be done. For instance, you can give some iron-loaded antibodies against the CD34, and then you have them run by a magnet, and you can pick them up this way. Or once the graft is being given, there's some way of doing manipulation to concentrate the stem cells and take out as best as you can all the T cells, which are thought to be at least a potential risk that you're reintroducing the disease. That by itself is associated with some risk as well, so there are some pros and cons to be weighed. The second step is then you give this person really strong chemotherapy to get rid of their immune system. The technical term for that is the conditioning. And even though there are different protocols around, or there are different protocols around for this high-dose chemo, you can still think about them as having low, intermediate, or high intensity. And as you may expect, the higher the intensity, the higher the toxicity, but maybe also the higher the potential to fully eradicate the immune system. The most commonly used protocol in the arena of MS is the so-called BEAM protocol, which is this cocktail out of these 4 chemotherapies, and then ATG is given. And these are basically cytotoxic antibodies against T-cell lymphocytes. So this is a different way of trying to reduce the number of T cells which come through the graft and eliminate those. Then the third step is the actual re-infusion of the stem cells themselves. So this time there's not chemo in there, this time the graft is in there, and you give additional GCSF, again with prednisone coverage, to speed up the recovery of the hematologic recovery. Overall, you can think of that patients are hospitalized for 3 weeks. The mobilization, the apheresis is done on an outpatient basis. They are then admitted for a 6-day course of high-dose chemotherapy. On the 7 days, that is our day 0, they get the re-infusion of the stem cells, and then they are discharged when their neutrophil counts are 500 for 2 days, which is typically around day 11 or 13. So that's in a nutshell the stem cell transplantation. However, people are not done yet. So there's, for a long period of time, there are additional supportive and prophylactic measures which need to be done. So different cell lines come back in different time windows. The platelets come pretty much back at the same time as the neutrophils come back. Red blood cells take a little longer, but the average person will require both transfusions of platelets and red blood cells as part of their stem cell transplantation. Then there is a schedule for infection prophylaxis as listed here. So quinolone until resolution of the neutropenia, fluconazole, either IV or oral, until resolution of the myositis. These people take Bactrums for 6 months against pneumocystis pneumonia, acyclovir for a year against herpes simplex and zoster, and all family or close contacts need annual flu shots. In addition, they get monthly their IgG level checked, and if it falls below a certain threshold, they get IVIG. They have EBV monitoring for 6 months. If they are positive, they get a course of rituximab. and that's with the that is because of a risk of transplantation, which is called, let me see if I get this straight, post-transplant proliferative disease. It's a little bit of a tongue twister for me. And then they have also CMV monitoring for a year and get ganciclovir if needed. Also think about they have a newborn immune system. So they lost all their vaccinations. They need all back their vaccinations. So starting at 1 year after the transplantation, they basically gave through all the vaccinations you went through in your infancy, more or less. So they have a schedule of multiple vaccinations. Let's talk about toxicity associated with stem cell transplantation. Generally speaking, we think about the short-term and the long-term toxicity. And as you may imagine, it is very normal to have low cell counts during certain parts after stem cell transplantation, which is associated with a risk of infections or hemorrhage. These people feel crappy for a week or two. That is very clearly, but they have malaise, they have mucositis. There is a risk of liver organ toxicity, primarily liver toxicity based on the amount, based on the chemos you're giving. And then there's something which is called engraftment syndrome. That's a fibral syndrome roughly 2 weeks after stem cell transplantation, associated to the introduction of pro-inflammatory cytokines when the neutrophils come back, and typically presents with fever, rash, but can have also other medical complications. In the setting of MS or possibly other neurological disease, we have another yet a risk of short-term or in the short period after stem cell transplantation of neurological worsening. So we mentioned already the risk of relapse in the setting of GCSF, but also MS patients don't do well with fever. MS patients don't do well with immobilization, so they may have neurological worsening based on that, and that at least could potentially also come with a risk of permanent neurological function. In the long run, you're obviously concerned about opportunistic infections. People after stem cell transplantation, whether done for MS or other reasons, have a long-term risk, increased risk of cancer, such as especially leukemia years later, and there's a risk of infertility or amenorrhea. Mortality is something we have to speak about to our patients, and here on the left panel you see mortality over different MS trials over the years, and we nowadays quote a roughly 1–1.5% mortality to our patients undergoing this procedure. Higher mortality is associated with higher MS disability at baseline. And then also if you do this what's called double purging, so graft manipulation and giving ATG. And so the reduced mortality in more recent trials is felt to be associated with better patient selection and using less intense chemotherapies or conditioning regimens. With that much as a background, what are we even talking about? Let's move on into where are we with autologous stem cell transplantation in MS?
Annette, before you start,
yeah.
Can I just ask one question
Sure.
about, are there any tests that can be done on someone who has had the preliminary elimination of their normal hematologic system to make sure that it's completely gone? Is there some way of judging that this patient had a complete eradication of their old immune system?
You can check this afterwards. In this time period, you don't want to kind of like, so it's kind of a pretty set standard treatment protocol, which is being used all the time for different conditions. So I think there's no really question anymore with this regimen that you're getting rid of it. But if you ask me, which way do we prove this? I don't think that's part of any protocol at this point. Afterwards, obviously there are sneaky ways or sophisticated ways of checking what are the what is old immune system, what is new immune system, and I actually come back to that. But we are not checking that, and there's no specific test we're doing at the 6th day of the chemo. Are we done? Do we need to extend the chemo before we move on? No. So It started maybe in the early 90s, so started with some individual case reports and small case series, and then you have what they often refer to as phase 1 trials, but it's not in a technical term truly a phase 1 trial, which would be obviously healthy volunteers, which you're not doing for this intervention, but it's more like feasibility trials. Those were in the late 90s, early 2000s. They focused primarily a little bit what was considered last resort. So advanced patients with advanced disease, many of them had secondary progressive MS, but we have learned over time that these are not the patients which are benefiting. The patients which are benefiting are those with relapsing remitting MS and with early disease, or at least have a better outcome. And while the MS community figured this out, the transplantation community figured out on how stem cell transplantation by itself can be given in a less toxic way. Nowadays, the stage of research we are now, that we get international or national registry reports, that we have phase 2 open labels, and we have actually already one comparative trial, which I will review with you. And where will the future bring us? So there has been years of discussion, including people of our group, on when is the international phase 3 trial coming, but there are significant challenges to that. One challenge is something which we normally feel very good about, that is this rapidly evolution of new, better treatments which are more potent. But if you think about planning a trial, that is a moving target, and with that becomes very challenging. It also becomes very challenging on an international level, because when you think about different countries having different access to medication, potent medications, or different standards of care. So that has brought this discussion still being in the discussion phase and not being really moving much forward at this point, in my view. So what I will do with the next few slides, I will show you basically very recent publications which came out on stem cell transplantation. Very egocentrically, I give you obviously the trial from our group where we are involved with, but it is indeed a unique trial in many ways. It's a 5-year prospective study, so many trials in the past were 2 or 3 years, so we know that if we're thinking about the outcome, we have to think in the long term for the outcome. It's a multi-center, open-label study for poor prognosis MS. Basically, people like I showed in the opener my patient story, who have significant functional decline while being on standard treatments associated with sustained loss of function. Funding comes to the NIH. And one of the things which are also unique is, and I'll come back to that a little later, is that we have composite primary outcome looking for survival and basically having absolute stability of their MS, including all the components we're looking at: disability, progression, MRI, stability, and no relapses. The pre-specified 3-year report was published early in JAMA Neurology. At this time, actually, the 5-year data of all patients have been collected, and we're moving towards a publication in that. The inclusion criteria are listed here. So basically, the whole trial was very much trying to focus on what in previous trial was found to be those patients who seem to benefit most, and the goal is very much early intervention in poor prognosis MS. So they are looking at relapsing remitting MS with a fairly low disability level, with a treatment failure defined as having had at least 2 relapses in the last 18 months associated with EDSS progression while being on treatment. And each individual participant had to be reviewed by a panel of national MS specialists and the stem cell transplantation specialists before they could move on. You see here the demographics listed here. So our average person would be in the mid to late 30s. We have the typical gender distribution. On average, patients had 5 years of disease, and most of them were on 3 to 4 prior MS treatments.
Is there a reason why you weren't doing primary progressive, or was it just more applicable to more people?
I'm trying to be good girl and repeat your question. So the question is, why not primary progressive? Primary progressive were in other trials found to be not particularly responsive to stem cell transplantation. They were clearly included in the very early phases, in the feasibility phase, and while it was feasible, they wasn't found to have any benefit. And the baseline EDSS 4.5, which is much lower than many of the other studies in this field. I will start with safety, and obviously autologous stem cell transplantation, you have a whole bag of anticipated frequent side effects, primarily related to low counts and infections. We had one serious infection in one person prior to stem cell transplantation. There was a person who developed a pulmonary embolus associated with HIT, so heparin-induced thrombocytopenia, and with immobilization, and was actually did not move on to stem cell transplantation on protocol. She since received stem cell transplantation off protocol and has been doing actually fairly well without complications. Then there was a total of 8 grade serious side effects not related to cell counts or GI symptoms. There were 2 late suicide attempts, or 2 suicide attempts late after stem cell transplantation, depression, respiratory arrest, and metabolic derangements. Actually, 2 patients died in the 3 years after stem cell transplantation. Their death, however, is considered to be unrelated to toxicity of the regimen. Of note, both were found to be not responsive to stem cell transplantation, had previously met endpoints, clinical endpoints, and one person died of MS progression, roughly 2.5 years after stem cell transplantation, and one died of worsening of asthma, which was a pre-existing condition and previously cleared by pulmonology to go into stem cell transplantation. The main outcome in this trial was something which nowadays has a new term and has really the sexy thing in the MS field right now. There's no evidence of disease activity on NEDA. So that means that people have no newer enlarging T2 lesion, have no contrast enhancing, no relapses, and no confirmed worsening on this EDSS. And the 3-year outcome in this trial was found that 78% of these patients had absolute stability in this of their disease, and then between 90 and 100% if you look at this individual components of this composite endpoint. Just to put this a little bit in context for you guys, what NEDA data do we have on what we consider our potent treatments in the MS? So natalizumab, like Tysabri, retrospectively at 2 years, 37%, alemtuzumab, depending which trial you're looking at, 32 or 37%. And these are the strong guys in the field here.
So Annette?
Yeah.
MRI-free survival 100%. But one person died of progressive MS.
These are the 3-year data, and so that MRI-free survival means that nobody had MRI disease activity at the 3-year mark. The patient I introduced you before had an MRI abnormality at 3.5 years. So these are the pre-specified 3-year data I'm showing you today because I don't have full access to the 5-year data.
I assume the person that died of progressive MS had MR progressive.
No, she did not. She had a clinical relapse, and she will be captured under relapse. So she brings this down here. This person did not have MRI progression.
Brain MRI, or where was it?
We're talking brain MRI. Sorry. Brain, yeah. Any other question about this before I move on? Did I clarify your question?
You did.
Okay.
Hard to believe, but you
Okay. Then obviously the trial looked at some other functional components which are frequently looked in MS trials, and they were found to have stabilization or improvement in this functional assessments. And this is maybe the time where I need to remind you again what type of patient cohort we're actually talking about. So this is a patient cohort with poor prognosis MS, where they have demonstrated all significant progression while being on treatment before. And so taking this in consideration, this is obviously very exciting data from our standpoint. Now I'm coming back to your question, Bruce, in terms of immune assays. As I said before, the hypothesis is that we have long-term remission due to persistent immune modulatory effects. If you only have a temporary effect on the disease, you may think of that this is related to just the chemo effect by itself. And at this time, I have very preliminary data to show you, Bruce, but they basically, this is something which is part of the study. We will learn much more about once 5-year data has been analyzed in that regard. But the preliminary data are that something which was seen in some other studies before, that the CD4 memory T cells have not recovered back to baseline at 2 years, that other cell counts typically come back between 6 to 12 months, and maybe the most important part is this one, that if you do high throughput deep sequences of T cell receptors on an individual basis, you will see a different repertoire of T cells. They have not found the dominant T cell receptors from prior to stem cell transplantation, but a new repertoire of T cell receptors, which suggests that indeed we'll have a new repertoire consistent with an immune reset. That's the only data I can show you. I know it's not entirely what you were looking for, but that's the data I can answer.
But you introduced me to a wonderful term, immune reset.
Yes. Okay. I will move on and tell you about the other big trial which has been published earlier this year. This is a randomized comparative trial which included secondary progressive and relapsing remitting MS with similar having decline while being on treatment and having enhancing lesion while being on treatment. They had 2 arms. One arm did basically pretty much the same thing as in the Hall trial, so autologous stem cell transplantation using the same protocol of BEAM and ATG versus mitoxantrone every 6 months in association with IV prednisolone on those days. You see the demographics listed here. Notable is maybe that the median range, so these are patients with higher levels of disability compared to the other trial I introduced you to. Overall, their demographic seems very balanced, maybe with the exception that there's a higher degree of patients with relapsing remitting MS in the mitoxantrone arm, which by our understanding would almost favor more this arm in terms of treatment response. The primary outcome of this trial was the cumulative number of new T2 lesions on MRI over a 2-year time frame, as the panel on the one side shows, and there's a statistically significant benefit and superiority of the stem cell transplantation compared to mitoxantrone arm. And then you see some of the secondary outcome measurements was this basically spelled out by year. They don't have much in terms of clinical outcomes to report, and it shows a little bit some of the problems with this trial in terms of originally was actually planned as a phase 3 clinical study with a primary outcome of a confirmed EDSS progression, but then there was lower than anticipated recruitment. So the study in the end was revised and we have low power for clinical outcome. Nevertheless, they can show that autologous stem cell transplantation was associated with a reduction in the annual relapse rate, whereas other clinical outcome measures did not really show any favoring of one arm or the other. Adverse event, and I basically quote you directly the authors. Early side effects were expected and occurred in the majority of patients. Severe side effects were seen only in the stem cell transplantation arm, but resolved without sequelae. And I you may not be able to read the sepsis, late engraftment, prolonged hospitalization, systemic candidiasis, CMV reactivation, engraftment failure, and ATG reduction. I forgot to mention that ATG, which is a medication to reduce the reintroduction of T cells, is very poorly tolerated. There are two more publications of this year. The contrast to the first two publications I reviewed with you is that these are actually low intensity regimens, conditioning regimens, which reduce the lymphocytes, but are actually not myeloablative regimens. Nevertheless, they followed up with stem cell transplantation after this conditioning regimen, which is a little bit controversial or critical, or it's the role of stem cell transplantation after you fully eradicate the immune system is not really clear. There's still some group working on that, and the first study is a small study on looking at enhancing lesions as their primary outcome, and they describe a profound effect on MRI inflammation and relapses, but that this regimen is unable to completely abrogate MRI or clinical disease activity. The other publication is on a non-controlled case series of relapsing remitting MS and off protocol treated secondary progressive MS over basically a 11-year time period. They used various regimens on this in a single center. So for me, teasing out the exact data with so many variables is a little bit difficult, but you also described that 50%, that they show a 50+ % improvement in clinical EDSS, so that they had functionally gain of 1 EDSS point lasting up to 5 years. With that, I will actually move on and talk about what is our group doing, what are our main projects at this time, other than obviously following up on the whole study. We'll have stem cell, we're looking at, we have another protocol which is active and ongoing, which is for non-responsive rare autoimmune diseases, from neurological autoimmune diseases, and to date we have included their MS, NMO, Rasmussen, and stiff person syndrome. We are following up on patients who were involved in a local prior study around 1999-2000 for their long-term outcome. Dr. Georges has is working on the national outcome of patients who have MS but happen to have another condition that they need to go on allogenic stem cell transplantation and see what happens to their MS. And then we are involved with upcoming clinical trials. I'd like to review with you our experience with other neurological conditions, and I'll start with refractory NMO. I believe that most of you, even though we have so many nice visitors here today, that NMO is also seen as demyelinating disease, which, different than MS, is associated that you have serious relapses. So a single relapse can be life-changing for these patients. And we have no real standard treatment other than immunosuppression, and the most popular and most effective treatment seem to be rituximab. So stem cell transplantation has been done in patients who have this condition as well. And earlier this year, there was a publication from the European Bone Marrow Transplantation Registry reporting on 16 cases over basically a 10-year time frame. They described that these patients with a serious condition demonstrated some stabilization, at least temporarily, but that they also had breakthrough disease. At last follow-up, 15 of the 16 were alive, while one had death due to NMO. Of the 13, however, 13 of those group, however, required further treatment. And that included what I think of pretty drastic measures in terms of undergoing a second autologous stem cell transplantation, or 3 actually moved on to receive an allogeneic stem cell transplantation. The authors propose that based on this experience, there are two things we may consider in this field, that you may want to introduce B cells depletion as part of your conditioning regimen. Basically, we know that NMO seem to be associated with the B cells, and so if you effectively reduce the B cells, you have a lower risk of relapse after stem cell transplantation. And very much in contrast to what has been done in MS, that you may want to early reintroduce maintenance therapy after stem cell transplantation. This is something which is not being done in patients who have had with MS who underwent autologous stem cell transplantation. Earlier this year, basically last month, there was this big meeting in the area of MS, the ACTRIMS meeting. There was the group from Calgary reported on 3 cases they had stem cell transplantation on since 2011. All had clinical stabilization of their relapse rate and improvement of their EDSS. Of note, 2 of the 3, however, remained aquaporin 4 antibody positive. Our team, we have a total of 3 patients here in Seattle since 2009 who have undergone autologous stem cell transplantation with this condition, and are in collaboration with a center in Sweden, which is using the same protocol, and there are 2 additional cases. At last update on those patients, 4 of those were stable. However, we had 1 death related to a fatal NMO relapse a little bit more than 2 years after stem cell transplantation, one of these cases.
For the MS transplantation trial that you just showed us, are you saying that you're not depleting B cells with your conditioning?
No. So rituximab is typically not part of the conditioning regimen, the BEAM protocol is kind of immunosuppressive, which are the these 4 cytotoxic agents, which are more global. They are T and B cells, but they are not specific. Rituximab is not part of the protocol. That may change because our understanding of the use of rituximab, or nowadays ocrelizumab in MS, has obviously changed quite a bit since many of these studies were done. But the most common part is no specific B cell depletion at the time of the conditioning.
But you said it was myeloablative. I mean, presumably you're getting rid of everything.
But basically you're getting rid of the precursor cells. Yes, and it's kind of like a global immunosuppression, whereas rituximab is obviously targeting with the CD20 antibodies the B cells specifically. And actually there are no CD20 antibodies on B cell precursor cells. So you're only washing out the ones which are matured at that time. You're not washing out their breeding colonies. So CD20 is not on the plasma cells, and CD20 is not on the B cell progenitor cells. So if you give rituximab, you would actually not target them.
And it would seem that in this category of patient, you have a particular advantage in following them having nothing to do with disease relapse, because you can look at what people believe is pathogenic antibodies to aquaporin 4 and see if the antibody's been eradicated, and then if it should come back.
But this doesn't seem to be.
Well, that's only 3 patients, and
yeah.
you don't know whether that might have been a less effective protocol than these others.
And I don't really know, I have to say. I'm sure it's part of our protocol, but I don't have the data, so I don't know that here for now. If we do this, I hope we are doing that, but I don't know that for sure, and I cannot confirm this here right now from the top of my head. But if we go back to the MS field, there you would think about oligoclonal band may be the equivalent.
Well,
okay, somebody doesn't believe that. And I think it's true, it's not. It's very non-specific marker, as we all know. But if you look at these studies which had looked oligoclonal bands before and after, if I'm not mistaken, in most cases, they were found after as well. So there is some signature we are not getting rid of, even with intense measurement such as autologous stem cell transplantation.
I mean, it would be a big deal if you have a relapse in one of these patients who had no antibodies to aquaporin 4, because that's still a little bit controversial, whether it's pathogenic or just a biomarker.
It is. And then we have to acknowledge that there is a portion, 25 to 30% of patients with NMO spectrum disease who don't have the antibody to begin with. So there's mock antibodies may have been found in some of these patients. So this is probably not the only pathogenic antibody. That's the best we know at this point. So that's a moving target as well. But I agree with you. So the next condition is stiff person syndrome, and the Ottawa group has published 2 of the 3 cases recently, the 2 where they have long-term follow-up on, and we know from personal communication that that 3rd case was short-term follow-up only. They describe in these 2 cases remission with sustained and marked improvement of their symptoms and function, and basically return to their pre-morbid function with a follow-up of 2.5 or 4.5 years. And what they describe in the clinical course, which was notable in both of these patients, is they don't have this abrupt, immediate functional improvement after stem cell transplantation, but they have a steady, gradual improvement of function. Our team, in collaboration with Denver, has done 5 cases of stiff person syndrome. And as I started with a patient story, I actually also would like to end with a patient story, because this is a person several of you guys have seen while she was hospitalized. So this is the first patient of stem cell transplantation with stiff person syndrome done here at the UW. She is now a 27-year-old female, for those who don't know her, with severe refractory stiff person syndrome, diagnosed based on Neurexam, anti-gut 2065, and EMG, with extensive work at the University of Alabama. There would be not enough slides for me to show what tests she all had. Her onset was in early 2013, and with a remarkable and rapid progressive decline. She was treated pretty intensely, initially with prednisone, several courses of high-dose IV steroids throughout her course of disease. For long stretches, she was on IVIG every 2 weeks. She got 2 rounds of plasmapheresis, 3 infusions of rituximab, and then transitioned to CellCept. On the symptom management, she had increasing doses of diazepam and baclofen. She needed a baclofen pump, and even with the baclofen pump, she was really, really poorly controlled and needed frequent rescue medications. To paint the picture a little bit, by early 2014, she was maximum able to walk a few steps, basically with assistance. All ambulation were done by a wheelchair, which she was unable to propel. She had several falls, very impressively for startle responses with unexpected noises. Several injuries due to these falls, also joint dislocations for the severity of her prolonged muscle spasms. And as her disease progressed, she had more and more difficulties with shortness of breath and required oxygen during these episodes. She was seen in March of 2014 by Dr. Weiss, who did an EMG and found the typical findings, or the findings we would anticipate with stiff person syndrome, that you basically have co-contraction in agonist and antagonistic muscle groups and continued muscle activity in a number of muscles. So she came to Seattle for evaluation for stem cell transplantation, but when she arrived here, she was doing so poorly that she was actually admitted to the UW Medical Center. She received another course of plasmapheresis and was restarted on repeated IVIG. Then in May of last year, she underwent stem cell transplantation. And I'd like to end with a few videos of hers, if I'm smart enough to do that. So I have 2 short clips from when she was in the hospital, showing you a little bit her ambulatory skills with 1-hour physical therapists, and very stiff gait, not a functional gait at all. So you have basically a 2-person assist. You may not see this, but there's a wheelchair following her. Can you guys see that? Okay, so I think you get the idea. Then this is from, I'm not sure, is that better if I do it larger? Maybe. This shows some of her spasms, which were spontaneous or triggered by noises, which could last several hours, and were basically old body spasms. I think it's pretty obvious.
She looks to be in pain as well.
These are very painful spasms. So she was very poorly controlled. Then I show you a video from February 2015. Her course thereafter, which is basically, what is it, May to February, 7 months after stem cell transplantation. She had thymectomy in the meantime as well, so I don't want to belabor that. And so that's her walking. And then actually I got through Bernie, who works with us here, a very recent one I couldn't help to put in here as well, because this now looks like a very healthy lady now, casually with her star cup in her hands. So I just thought like this is the opportunity to let you guys know who got to know her during the hospitalization, to give you an update in this case. Going back to my slides here for a moment, my take-home message first from today. So stem cell transplantation is fundamentally different than immunosuppressant. Obviously, for that matter, also our regular standard therapies. It does not depend on the persistent immunosuppression or lymphopenia. It has found to be effective without being followed by maintenance therapy thereafter to induce a sustained remission in active MS. It is an invasive regimen, no question about this, but it may promise benefit in some highly selected patients and possibly other autoimmune diseases. And there's an increasing body of data which support the immune reset, which is felt to be the reason of the sustained treatment effects. With that, I'd like to thank for your attention, but I also like to take the opportunity to introduce you to our team. Dr. Richard Nash is the PI of the HOLT MS study. He, a few years, moved from the University of Washington to the Colorado Cancer Center Institute. There, next to it, you see the team of the Fred Hatch. So this is Dr. George Georges, who is the PI of many of our ongoing projects, with his very supportive team around it. Bernie, who's here today, is clearly a strong force on these endeavors, keeps me straight all the time. And then we have Christine next to her, who is retiring, and Jessica, I recognize here in the audience, haven't met her personally yet, is replacing Christine. And then I think I don't need to introduce most of you to the faculty here who are otherwise involved in this project. Okay, these were my presentation. More questions? Okay, there don't seem to be any questions at this point. Questions in the audience? Christoph.
The very fact that it only seems to work for intermittent MS, doesn't that point almost inevitably to the fact, or wouldn't that suggest that intermittent MS is probably caused by something in the environment, whereas the other forms that are not responding to this type of therapy have an endogenous factor that is contributing to the disease?
Okay, so Christoph in the audience wonders whether that because relapsing remitting MS is responding versus progressive forms are not responding, whether that means that the progressive cases have some endogenous component rather than environmental to be responsible for this treatment effect. I'm not sure if that's the only answer. We obviously think about this as a continuum in the disease, with having neuroinflammation, neurodegeneration, basically at all stages of MS. At the very early stage, the person coming in with optic neuritis today has, if you do a biopsy on them, will have signs of neurodegenerative changes in that early stage already. And as always with these trials, similar with our DMTs, it's never an entirely black and white response or not response. They have found to be less responsive. The primary progressive were found, to my knowledge, really no definite response. And then the others, you may have seen some improvement. You see that many of the clinical trials actually to date still include secondary progressive MS. So it's not a black and white yes or no, but it's a spectrum. But those with the best response were also found to be, again, relapsing remitting MS, which is very consistent what we see with our disease-modifying therapies. So I don't think it's a black and white, but there may be, there are probably different components to that.
On screen.
On the screen, okay. What is the lower age limit for a patient to be considered in this study? We'll have, depending on what type of diagnosis you're talking about. So I think we can be in personal communications about this. So we have this, let's say, umbrella protocol, which captures a lot more rare autoimmune diseases than I've presented. And that does include some rare pediatric neurological diseases as well. There is no specific cutoff. I don't even think that we put in an age cutoff for NMO or Rasmussen, so no lower limit.
I think you were getting to this, and maybe you explained this, but you're following the T cell repertoire with time in these guys after bone marrow?
Yes, somebody is, not me.
But somebody is
yes.
In your group you're following,
yeah.
and are you slowly seeing some expansion of T cells that are recognizing epitopes now, or?
So we personally in the local group are not involved in these immunological studies at all. This is in international collaboration. So Dr. Paul Muraro is the head, in my understanding. The ITN network is involved. So this is nothing where I'm personally involved in. So I cannot give you the exact state of that, but obviously they are busily working on those things, and we'll have updates as we move along. So I'm personally not that much involved in this research.
But it must be true. They look very healthy. They're out and about, being exposed to illnesses. They'd probably be dead if they had no, active immunity.
Okay, I may have not gotten the
detail.
detail.
Now they have antigens. I mean, they still have the same antigens in their brain. Have they, did that one T cell say, "Oh yeah, that's right, I forgot. We're going to recognize that as cell."
Mm-hmm. I have no data to along that line.
It's an amazing story, and that for somebody like you who's watched MS for many, many, many years, this must feel like a promising new direction. Admittedly, extremely aggressive, but promising. It can return a person almost to a normal life.
So kind of like I personally have followed several of these patients. I started with the one which was my first stem cell transplantation, and it's really nice to see how much in those cases, and I have another one which I followed very early on and have followed now for several years. Actually, both of them are considered to be treatment failure in that trial, but when they come in, they kind of almost smile. They're like, I don't consider myself a treatment failure. So this one person had one enhancing lesion. The other person may have had a relapse or a pseudo-relapse when she was not here. She moved to San Francisco, was treated with steroids somewhere else. MRI was unchanged. Formally, we declared her a treatment failure for one relapse. No functional impairment. She doesn't consider herself a treatment failure. She was twice promoted since. So kind of, it is exciting. It's exciting to see these patients because these are obviously the type of patients you worry about very much. I'm seeing this decline. If I kind of let the second patient, I've been seeing kind of my own recruitment, if I can put it this way. So we saw a lot of referrals from patients, from providers around the country. But those from my own patients I've been following, the second person in this study, started to have really aggressive MS and enhancing lesion on Tysabri and things like this, where you just feel like, what do I do with you? You are not doing well at all. And she started to get cognitive difficulties on top of her physical limitations at that time. She has a 2.5 sustained EDSS improvement after stem cell transplantation. No word about cognitive difficulties anymore, twice promoted. So she's doing very, very well, and that's exciting to see. This is, however, obviously in highly selected patients. I have a lot of patients coming in. They think about stem cell transplantation as a cure, it's sexy, and it's totally not appropriate for them.
Thank you, Annette. That was great.
You're welcome. Thank you.